welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Opioid Prescription Control When the Corrective Goes Too Far. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handout, sign-in sheets, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on March 31st, 2019, and 2 years for social workers, expiring on March 31st, 2020. I'm Carolyn Byrne, Director of the Office of Community Affairs at the Alabama Department of Public Health, and I would like to introduce our presenter today, Dr. Stefan Cortez, a professor in the Division of Preventive Medicine at the University of Alabama School of Medicine. Welcome, Dr. Cortez, and thank you for being here. Let's get started.
It's a pleasure to be here. All right. Well, thank you for tuning in whenever you get a chance to watch this. It's a real pleasure to have a chance to speak to a wide audience of interdisciplinary professionals about a topic that's so important to us at this time. So the title of this talk is Opioid Prescription Control When the Corrective Goes Too Far, and I'm affiliated with both the US Department of Veterans Affairs and the University of Alabama at Birmingham, but the opinions here I present will be my own. I'm faculty at UAB, as I mentioned, a diplomate of the American Board of Addiction Medicine, a professor, a member of the Opioid Safety Initiative at my institution. If this discussion is interesting to you, you're welcome to follow me on Twitter. I have some disclosures. I have no pharmaceutical grants or honoraria or contracts or any history of depending on that industry. I did own stock in a stock portfolio from some Abbott and Merck, which was a very small percentage of what I had, but I did sell it. My wife has that as well. She also has some Johnson & Johnson. I'm not sure it's necessarily relevant, but we need to disclose. The opinions here are my own and not those of any agency that I work for. Now, this talk, as we think about opioids and pain and addiction, may convey a kind of professorial certainty. That reflects my best reading of the data at this time. But this is a very complicated terrain we're marching into, and nothing is fully settled. So we may learn new things over the next few months or years that change the import of what I say today. This talk also includes learning from people who I want to thank for their help, including Dr. Adam Gordon from the VA Salt Lake City and University of Utah, Dr. A.J. Manhapra from the VA Hampton Healthcare System in Yale, and Dr. Sally Sattel from American Enterprise Institute in Yale. And all of us interact, and that doesn't mean we agree on every single idea. We find ourselves in a very interesting predicament, and I've chosen to display this with a cartoon where a physician is sitting in the office with a patient sitting on the table, and the doctor is surrounded by boxes that say CDC Guideline, Drug Enforcement Agency, Overdose Epidemic, Prescription Drug Monitoring. And the doctor says, plaintively, too many people are dying. The situation's out of control. I kind of thought they were helping you, but right now I need to stop your Lortab pills. And the patient looks at the physician anxiously and says, what did I do? And right outside the window, of course, you can see a tragedy. Someone injecting, and a graveyard full of syringes. We find ourselves at a very difficult time, and this cartoon is meant to display something as a cartoon, i.e. the idea that there's two kinds of people, which is not always the case, and the idea that people's care in the doctor's office is being changed in relationship to something that might not be happening to them, but to someone else. But that's not always the case either. These two environments, the one inside and the one outside, sometimes do interact. There are a lot of questions we can ask about opioids today. They include, how do we treat addiction? How did so many people develop addiction? To what extent did doctors and nurses and the health industry contribute? How do we get out of this? Each one of these questions can be debated. What we're going to talk about today is one part of a very complex equation. And it's the control of prescriptions, because so much hope has been placed on the idea that if we control them properly, that will end the problems that we face today. And as you'll see, I actually would agree there's a history of overprescribing, but I'm not sure the control emphasis is getting us quite where we need to go. Just to give you a window into some of the initiatives we see today, there's a map that shows several states. Where you see orange, that reflects that there's some requirement of authorization in order to get certain prescriptions. Each state's color code reflects different legislative acts that have been carried out as summarized by the National Coalition of State Legislatures. And more states, the gray ones, are acting as we speak. There are initiatives from pharmaceutical companies, including those that handle our prescription drug benefits. There's even a little window from Stat News suggesting a group of physicians and patients have drawn some opposition to an initiative. I'm part of that, so I will get you into this, but I wanted you to get a sense that a lot is going on. To bring this home a little bit more forcefully, I want to show you an image of a letter from an insurer, a pharmacy benefits insurer, saying to a patient, we've looked at the prescription that your doctor thinks you need, and we don't think you should get it covered by your insurance plan. I actually highlighted some text that you may not be able to see, but I'll explain. The insurer says, only you and your provider can make decisions about your care. They deny that they are asserting anything about the appropriateness of the care. But they say, look, your health plan only covers a certain amount, and that's all we can cover. It's actually the amount of 90 milligrams of morphine or the equivalent in the course of a day. That means that as we make changes in prescriptions, it's hitting home for individuals who've historically been on higher doses. The structure of this talk going forward will be to discuss the evolution of the US opioid crisis, to introduce some reasonable ideas about pain care, including the Centers for Disease Control Guideline and what it says about opioids, to describe opioid pill control initiatives in much more detail, and describe the problems associated with overcorrection focused on pills. First of all, let's acknowledge a tragedy. The number of people who have died from any drug overdose, as estimated for the year 2016 heading into 2017, but a one-year total, was over 64,000 people. As it turns out, roughly two-thirds of those had an opioid involved. What's an opioid? Well, in this category, it could include injected heroin that's purchased on the street. It could include pills that a person got from their doctor or obtained from someone else who got them from a doctor or diverted from a pharmacy, that include those same compounds that interact with the same centers in the brain. So these are known by Lortab, hydrocodone, oxycodone, OxyContin, fentanyl patches even. Opioids can also include illicitly sourced fentanyl, which is to say something like what you might get in a patch from a doctor, but actually made by manufacturers in Mexico or in China or even in the United States, and bundled into bags and sold as if it's heroin, or bundled into pills to look like it's Percocet or something that a patient knows and is expecting but is in fact not. Prescriptions, I should say, if you were looking at the previous graph, prescriptions of opioids rose pretty aggressively from 1999 to about 2010 in parallel with the number of those deaths, which gave us some hint that something about all this prescribing may have contributed to the public interest and the interest among people prone to addiction, and maybe even among people who didn't even have an addiction or any proclivity for it, to wind up with an addiction to opioids. That rise was in parallel until 2010, but things have changed a little bit since then. What I'm showing you here is a graph of an orange line that shows total opioid overdose deaths. Now, this line doesn't go all the way to 64,000. It's from the CDC, and it goes to about 42,000. The other line is a change in opioid prescriptions. It's a blue line that goes down. Those have dropped about 18% in the last 7 years. So at this point in time, the prescription drop is not producing a return yet, although some may hope that over time perhaps addictions might go away. But there's some complications to this issue. Now, when people see the previous line, the first thing they realize in that orange line is, look, a lot of those deaths have nothing to do with the type of pill that's prescribed or taken as prescribed. Isn't that line flying upward because of people who have wound up in the illicit market for heroin and illicit fentanyl? And there's really some truth to that. Here what I'm showing you is a blue line. The blue line is actually the number of high-dose opioid prescriptions, precisely the kind that the insurer letter was trying to stop. Those have dropped about 48% in the last 7 to 8 years. The orange dotted line actually is the estimated number of deaths in which medical examiners reported to the CDC that they found something that might have been a prescription-type opioid. That means they found residue of hydrocodone or Percocet or morphine. It doesn't mean that every person actually got a prescription. It could even be in some of those cases that they had heroin that turned into morphine when it was metabolized. But the line fully removes anybody who had heroin or fentanyl, and that's kind of a flat line. So what we're kind of seeing here is that high-dose prescribing has gone down, but the kinds of deaths that were supposed to be prevented by stopping those high-dose prescriptions haven't gone down, which again suggests we're dealing with a very complicated problem that we don't understand exactly. So the crisis has changed. Today, my estimate, based on looking at the CDC's website, is about 3/4 of the opioid-related overdose deaths in 2016 actually involved heroin or fentanyl, illicitly sourced for the most part. About 1/4 involved a possibly prescribed opioid without any heroin or fentanyl, and it was not necessarily prescribed to the person who died. So that's where we are. It seems to me that before we talk about the initiatives to change pain care, I need to say something about what does the literature show us in regard to pain care and the use of opioids in that process. Let's acknowledge chronic pain, which takes many different forms and is often seen as a disease unto itself, but the people with it are quite diverse. There are 23.4 million Americans who are thought to have severe and debilitating chronic pain. The estimate is 5 to 8 million are on opioids, typically pills, but sometimes lozenges or other forms for that pain. Chronic pain can be, for some people, just an annoyance. For others, it can be a terrible experience, and it is associated with suicide, so it can be devastating. Here's the sad thing about any and all individual proposed treatments for chronic pain. They've typically been tested with predominantly short-term data. Any single treatment, whether we're talking about yoga or opioids or ibuprofen, works typically for a minority with modest benefit. There is no particular silver bullet for a very challenging problem. For people who have common forms of musculoskeletal pain, like back pain and the things that many of us get as we get older, there are a number of therapies with good evidence to support them. And I've actually borrowed this slide from Dr. Aaron Krebs, whose trial we're going to talk about in a moment. But these are behavioral therapies, exercise therapies, and manual therapies that a VA Health Services Research Center reviewed and found to have sufficient evidence to be helpful. Now again, the typically shorter-term trials, helping a minority, but most of these therapies don't involve medicines and don't involve the risks that medicines might include, such as Tai Chi, mindfulness-based stress reduction, coordination and stabilization, acceptance and commitment therapies, all of them. And I actually talk about these with the people that I take care of. It's helpful to start with a good relationship when a person comes to you thinking that they will be helped by a pill. You're thinking maybe you should try this other stuff. It's really important to develop a relationship to have that conversation. Okay, what about opioids? This is my confession. I entertain 4 separate ideas about opioids for chronic pain. I can justify each of these ideas with review of the literature, and they're somewhat in tension with each other. On the one hand, I see them as crummy drugs. On the other hand, I think sometimes they're the last best option. On the other hand, they are sometimes quite helpful. And finally, they are not entirely spawn of the devil, even if you've been hearing that in the media. But the question does arise from time to time, as well it should. We have a very untidy record on the use of opioids for chronic pain. Why are they crummy from one point of view? Well, 20 to 60% of patients in randomized controlled trials stop them due to side effects. They simply can't tolerate the way the drugs make them feel. The estimates for people who would develop new onset addiction range across multiple studies. You see the number 1, which refers to one study that was cited in the Center for Disease Control Guideline of 2016. The National Institute on Drug Abuse published a paper suggesting that maybe 8% of people would develop a new onset addiction that they did not have before as a result of being put onto chronic opioids, but other papers show less than 1%. One of the things to recognize is we're not all at equal risk for developing addiction. A younger adult is at much more risk than an older adult. A person who has had a prior addiction to something else may have a much different reaction to these kinds of medicines than someone who has not. Separate from the issue of addiction itself, a meaningful percentage of people have problematic behaviors that are noticed in doctors' offices, seen by nurses, seen by social workers. A patient who seems antsy, who escalates their dose without necessarily asking permission, who calls repeatedly with a certain intensity. These problematic behaviors, sometimes called aberrant behaviors, depending on the study, between 3% and 20% of patients seem to have them. They may not signify a full form of addiction, but they represent something concerning. So if you had a medicine in which 20 to 60% of people said, I can't tolerate it, a meaningful percentage developed new onset addiction, and somewhere between 3 and 20% had behaviors, you would know that not the majority are necessarily getting benefit once you start it. On the other hand, why not spawn of the devil? Well, in long-term follow-up studies from randomized controlled trials, but looking at people after the trials ended, about 25 to 33% of people stay on these medicines long-term, usually at stable dose, and seem to be functional and doing okay. So that's the mixed record. Of course, some of you may have been watching the news, and the question arises, well, aren't opioids no better than Tylenol, according to a recent trial published in the Journal of the American Medical Association, actually published by Dr. Aaron Krebs, who gave me the slide I used earlier in this talk. This was a trial that was for adults with hip, knee, and low back pain. There were 248. There were people who reported that it was really bothering them and that their regular anti-inflammatory medicines had not been working. These were people who volunteered to be randomized, which means they were ready to enter a new course of treatment and try something out. That's not always the case with everybody. The two treatment arms in this trial included one where there was a sequence of opioids, one that was a little less potent and then more potent, then really potent, and they worked the doses up. In the other trial arm, there was a sequence of treatments that initially did not include opioids. Systematic use of naproxen, which is also known as Aleve, the high dose, Tylenol, ointments and gels, off-label use of a medication called gabapentin, other treatments, and finally at the highest level or at the when nothing else worked, a relatively low potency opioid called tramadol, which relatively few people received. Across an entire year of follow-up, which makes this rather unique, people seem to do about as well as each other. What does it mean? Well, we'll probably be debating this trial for a while, but my take is if the average patient with back pain says to me, you know, my ibuprofen isn't working, I'm probably not just going to start out by writing a prescription for hydrocodone. There's more to be talked about, more to be discussed. I shouldn't pretend that every time I write a prescription for an opioid, it's a magic pill that's going to make everything get better. But you heard me earlier, I think sometimes they're the thing that works. What about the CDC Guideline for Prescribing Opioids for Chronic Pain? This was a consensus document published in 2016. This may be the shortest summary you're ever going to see of a 52-page document written by an extremely large team. First of all, it says, try to avoid starting opioids if possible, but if you're going to do it, evaluate and document the projected risks and the projected benefits to the person you're caring for. It's very much a patient-centered judgment. It also suggests going for the lowest effective dose, and we are going to talk about dose shortly, but on average, there seems to be an association between being at lower dose and having fewer side effects, and maybe lower risk of overdose too. They suggest a very cautious review when considering taking that dose above the equivalent of 50 milligrams or 90 milligrams of morphine. I guess the question is, what is that? So a patient who takes 4 10-milligram hydrocodone pills a day, which is also sold under the name Lortab, is getting 40 milliequivalents. And most Americans who do receive chronic dose opioids are below 90 and below 50. 90 milligrams is typically something that would be, for instance, a long-acting opioid like long-acting morphine, 30 milligrams 3 times a day, 4 times a day. But because people develop tolerance, these doses can sometimes be quite a bit higher for a small group, although according to the Centers for Medicare and Medicaid Services, over 1 million people did receive over 90 milligram morphine equivalents for at least one day over the course of 2015. The CDC Guideline suggests regular follow-up with these patients, and then it has a very important and interesting recommendation for people who are already on opioids. It says for these people to evaluate the actual harms the patient is experiencing and the actual benefit as best you can tell. This recommendation is quite important for the people currently living at high doses because it does not say to take the dose down to a particular dose in order to change the patient's health or their risk. It says to make the decision based on how they are actually doing, and that's the 7th recommendation. Additional recommendations that I've mentioned including urine drug tests, prescription drug monitoring programs. There is one about generally keeping prescriptions short for people who have acute pain if you feel they really need to receive it. The evidence quality behind most of these recommendations, as acknowledged by the guideline itself, was low. That means that there is really not the strongest types of evidence we like to see when making medical recommendations, even though this area certainly needed some recommendations. So let's talk about the rise of pill control, because in many ways, the initiatives we discuss will typically invoke that guideline that I just mentioned, although they typically invoke it in a way that doesn't seem to exactly align with what the guideline said. Behind our rise in policies focused on pill control are two parallel hopes, or epidemiologic hopes. One is represented by the Zelda character Link, holding up a shield with stones flying at the shield. And it's the notion of shielding the patient from the risk of overdose or other opioid-related harms, which may include depression or changes to immune system, and shielding them by bringing the doses down. And that is an epidemiologic hope. The other one concerns the onset of addiction, and to represent that, I show 3 curves. The red curve is the rise, and hopefully, one guesses, the fall of prescriptions. The yellow curve is the rise of addiction, but it doesn't happen at the same time. Those people who are going to develop addiction, it takes time, so it's at some delay. The white curve is the rise and fall of deaths. Again, that would occur at some delay. And it's the notion that those are delayed from each other that's quite important, because you heard and saw the slide which presented the rise in overdose deaths, or the failure of them to drop at least, while prescriptions were going down. The counter-argument to that slide is to say, look, these things happen at a delay. You need to wait. Most of this talk will focus on the prescription dose control, and so you'll see the figure of Link pop up for the rest of the talk. So what are the dose control initiatives? Let's review. There are quality metrics that rate all healthcare providers that are based on the dose that they prescribe for patients who receive opioids. Those metrics take no account of the patient's particular health and condition, although sometimes they exempt people who are in hospice or have cancer. Essentially, if a patient's at over 90 milligrams, that counts as bad, according to these quality metrics, regardless of how they got there or whether they need it. There are restrictions from payers who, as you saw, sometimes say your policy just won't cover this. There is prescription drug monitoring programs. I personally find the programs helpful. There are mixed studies on whether they actually reduce overdose or fail to do so. But one thing that healthcare providers need to be aware of is that this is a window into the healthcare record that is shared with law enforcement. There's no warrant required for any law enforcement agency to search this aspect of the health record, and so that creates a little nervousness for healthcare providers and probably for patients as well, even though law enforcement certainly has a reason that they want to be looking. Long-standing policies have been in place in some states that have encouraged pharmacists to look for red flags, indicators that the prescription to be filled is not likely to be legitimate or put to good use. Pharmacists themselves are on notice from the Drug Enforcement Agency that their license is on the line when they fill a prescription, including a prescription for opioids. Some of those red flags include things like traveling from far away to fill a prescription. Now, if you live in a rural area, that might not be something you could avoid. They include a young person who looks like they're in withdrawal. They include a person who's been rejected by another pharmacy before. We could have a debate about each one of these. Obviously, law enforcement is very engaged on this issue. Medical boards are issuing rules, guidelines, and regulations. Employers that employ healthcare providers often have their own rules. And the Federal Food and Drug Administration announced in December that they were planning to institute new hoops, as they put it, for doctors to jump through if they wish to prescribe opioids. I put up CVS Health. I could have put up Express Scripts or any other pharmacy plan. They're all focused on trying to reduce prescribing dose. And again, you see that image of the state regulations. Not every state is regulating dose at all at this point, but several have or appointed boards to do that. Add to the mix a proposal for the payment plans that would cover Medicare Part D and Part C starting in 2019. The Centers for Medicare and Medicaid Services, at the day that we're speaking about this, is deliberating over a plan that they put forward to the public for public comment. they suggest that there should be a denial of payment for prescriptions at the point of sale, that is to say at the pharmacy, if the patient's total dose is over 90 morphine milligram equivalents. However, they do allow the patient and the pharmacist and the doctor to pursue an authorization from the payer to cover it, and they even propose to allow 7 days of medication to be covered while that authorization is sought. There are exceptions in that proposal for hospice and metastatic cancer. In sharing a quotation with you, I want you to hear those epidemiologic hopes coming through from an administrator at the Centers for Medicare and Medicaid Services. We're proposing new actions to reduce seniors' risk of being addicted to or overdoing it on opioids. That gets to starting addiction. That was the curves going up and down. And it gets to overdoing it. That sounds a little bit like overdose or maybe risks from high dose. We believe, it says at the end, these actions will reduce the oversupply of opioids in our communities. And we didn't talk about that, but remember when I said how most people can't tolerate the opioids they're prescribed? That means there's bottles with pills that sit in bathroom shelves that can be diverted, taken up by the teenager who rambles through grandma's house, sold around and used by others. So oversupply is actually a very important issue for the risk, particularly among young adults. Okay, let's talk about the data, because these are all policies, but normally we like to see strong data to suggest policies that would change healthcare. Data on the issue that might support restricting and reducing doses typically comes in the form of a study I'm showing you here, and I will explain that graphic that has very small print. This is a study by Amy Bonner, published in 2011 in JAMA, and they looked at veterans who had prescription opioid overdose deaths that appeared to be unintentional. That didn't mean that they always got the prescription that they died from, but these are people where the death examiner data said, look, it was a death from what seems to be a prescription opioid. And dose was a risk factor for death. And a red box is put there, and if you study the slides, you'll be able to see it. But essentially what it says is that being at a dose of over 100 milligram morphine equivalents put one at 7 times higher risk of this bad event happening than if one was at a dose of under 20 morphine milligram equivalents, which would be like taking 2.5, 7.5 milligram hydrocodone pills a day, relatively low dose. So dose has been associated with this bad thing happening in these kinds of large database observations. What can't be shown from this kind of study is exactly how the person died, what were the other substances in their body at the time they died, but this association has been found across multiple studies. It's important to note what else was found by Dr. Bonner. Other factors that predicted the event that we call overdose included substance use disorder, having an addiction diagnosis, having a psychiatric disorder. No one really knows exactly what the patients took at time of death. Being younger was quite a bit higher risk than being older. If you study the image, what you'll see is that a person who was over 70 had an odds that was 1/20th of a person who was between age 18 and 29. So if a person's risk is perhaps multiplied by being on high dose, at the same time perhaps reduced by being older, the risk of overdose is kind of a complicated animal. You might need to somehow combine those. Other medical diagnoses, particularly psychiatric diagnoses, were very important in this data. And the data also showed something quite curious. White individuals were more likely to have an event called overdose compared to black individuals. There is no reason to think that race itself protects against anything. The amount of pigment in our skin doesn't change whether you're going to have an overdose event. So this is probably a signal that there were some other things going on in the population that were hard to measure but somehow correlated with race in ways that we can't really know at this point. But just to say that there's a lot that happens in people who receive opioids and have these tragic events. So what about reducing doses? Does that make people healthier? A lot of doctors are doing it right now. I've certainly seen and encountered patients who volunteered for dose reductions and said, you know what, I feel a little more awake now. I'm not sure I needed to be on as high a dose as I was. This is a review from the Annals of Internal Medicine. It was published in 2017 by an excellent group. And what they did is review the world's literature, essentially, on trials of dose reduction. When this is done voluntarily in well-run programs, dose reduction can be achieved. Some people actually do feel better. That was a tendency in the data, although the authors called it low-quality evidence, meaning these were small trials or there were certain kinds of evaluations that could have been done a little bit better. But it was sort of promising. The authors also had very important statements about the limitations to what they were able to find. They said there were no studies of mandatory or involuntary opioid discontinuation. That's pretty important to know there were no studies of that at a time when that's what's happening. They also said there was insufficient evidence on adverse events, such as overdose or switching to the illicit market opioids, or the new onset of suicidality, that hadn't been well studied. That's also important at a time when we're making major policy changes. The guidelines that are available to us include many. I'm going to show you two, but they actually differ on this question of whether to taper and reduce the dose when a person is sitting above that 90 milligram mark flagged by the CDC guideline. As I mentioned before, the CDC's 7th recommendation says to weigh benefits against harms and to make the decision about what to do with dose based on what the patient seems to be experiencing. A guideline from the Veterans Affairs and Department of Defense, published in 2017, suggests that all people should be tapered if the dose is over 90, or if they're also receiving a sedating medicine in the benzodiazepine family. That would be like Valium or lorazepam. They also suggested the dose should be tapered if the patient does not participate in other forms of comprehensive pain care. And then they list another list of conditions that should cause that. The little picture that you see in the lower left-hand corner is just to remind me to say something. This is what the graphic for the guideline says. The language written in the text sort of differs a little bit from the graphic, so we're not sure exactly how they're supposed to line up. The language in the text says, consider risks versus benefits and decide whether to reduce the dose. This is different, yet again, from other guidelines, such as the one in Canada that was just published. Okay, what data do we have that might not favor mandating dose reduction, and what's the theory behind the data that has been guiding us thus far? One thing important to know is that there have been studies of what percentage of people actually have an overdose death if they've received a prescription. This is data from the Department of Veterans Affairs. It's over 1 million individuals in the year 2013. What you see, first of all, is that about 68% of the overdose deaths that occurred in individuals who received prescriptions occurred at less than 50 milligram morphine equivalents. Add to that 15% under 90 but over 50. Just 17% of the overdoses occurred above 90. Now, on the one hand, the reality is that the majority of people who receive opioid prescriptions are at those lower doses. So whatever event it is that we're trying to describe is more often going to happen at that low dose. They also noted that 77% of veterans dying of overdose had a substance use disorder or a mental health diagnosis. One of the important messages of this graph is that we don't fully understand the event we call overdose if most of the time it happens when the dose prescribed is low. One possibility is that a person prescribed a low dose takes half their bottle in one day. That would obviously be a very high dose that causes an event we call overdose. But it's also possible that they take something like what was prescribed, but have a moment where they combine it with other substances that affect the brain, and they wind up overdosing from the combination of those things. One might come back on this little point I made and said, but look, relatively, the risk of this event we call overdose surely is higher at high dose, right? And the answer to that is not always, maybe not in every study, but certainly in plenty of them, probably. So in many large databases, we do see that association between dose and overdose. But oftentimes, there are other prescribed and non-prescribed agents that also affect the brain. Human brains sometimes can develop tolerance to one substance, but they often do poorly with the clash of multiple substances that all seem to have the same effect of sedating. So imagine somebody who takes 4 as opposed to 2 of their Lortab pills, then drinks a couple of drinks of whiskey, then borrows some of their spouse's Valium or diazepam, and then perhaps scores an illicit gabapentin pill from the black market. At that point, you have 4 different sedating substances, and the prescribed dose was low, but all this other stuff clashed in the same individual. Prescription dose is a risk factor in VA data, but it's not necessarily the dominant one. It's actually not a risk factor in a study I'm about to show you from the Kaiser Health System. And to really understand why we're having such difficulty understanding the role of dose, we're going to have to talk about who is actually receiving high doses. What is the event called overdose that we're trying to prevent? This is a little bit of old school research of people who died from heroin overdose, back before it was completely contaminated with illicit fentanyl like it is today. In those older studies, A lot of the people who died of heroin dose died at low doses of heroin. They had what were called subtherapeutic morphine levels in their blood. This should blow your mind. How can you call it an overdose if the level of the metabolite is actually low? The other thing found in those studies, though, that other factors contributed to those events. Typically, the heroin user used in an unfamiliar environment, a moment of chaos, also very often combined with other sedating substances. That's the point I made about the pills, too. And finally, those individuals often had medical illness. So what we're calling overdose may best be thought of as a poisoning event, which sometimes results from a high dose, but often results from a combination of things. This is from VA data. It's now going to feel a little bit like review from what I said. I've borrowed this from Dr. Elizabeth Oliva from the VA. Again, remember, I'm representing my own views here. This is just their data. Opioid type. Longer-acting opioids are associated with higher risk of overdose. The risk seems to be increased in VA data with slightly increasing dose. A person receiving 120 milligram equivalents would increase their projected risk of a suicide or overdose event, and the models were run separately and found mostly the same results, about as much as having a diagnosis of post-traumatic stress disorder or alcohol use disorder at any dose. Co-prescription of sedatives, like benzodiazepines, increased risk, but so did all the other sedating pain medicines. Each class of additional sedating pain medicines adds to the risk, at least in these correlational data from the Veterans Administration. There are many other risk factors. I'm a little worried that this graphic is small if you're looking on your phone, so I'm just going to mention that some of those risk factors circled in blue include mental health diagnoses, post-traumatic stress disorder, AIDS, liver disease, and certainly a prior history of overdose and suicide-related event. Dose clearly isn't the full story. This is a paper published in January of 2018 looking at Kaiser data from Colorado. They were people who had received prescriptions, and the modeled outcome was overdose. And here, history of substance use disorder, mental illness, and tobacco predicted overdose events. I'm not saying that tobacco is a direct cause. I'm saying that there's something about the tobacco smokers that might put them at high risk. Being on a longer-acting opioid was associated with risk of overdose, but actually the dose itself was not statistically significant. So we have a mixed story, a complicated story we're still trying to figure out. Here's one way to think about dose. In all these large database studies, imagine studying thousands or even millions of individuals. Who typically receives those high doses? They're often very complicated people, and this picture is taken from the New Yorker, which produces a face made of pills. But who's the person that we're actually thinking about at highest risk? They have multiple pain diagnoses. They have psychiatric diagnoses. They may have obesity, substance use disorder diagnoses, either current or remitted. Higher rates of being on multiple drugs. That's what we call polypharmacy. Now, some people at very high doses have none of these risk factors. They're actually just benefiting from them and are going back to work. But in correlational data where you're looking at large databases, this is the tendency that is found. I already think I talked about this, so we'll skip this. For these people, the question arises, does tapering the dose produce safety? Remember what I said. For people on prescription opioids for pain, we don't have a randomized controlled trial of taking the dose down against their will. It's hard to figure out how they would consent for that. There is a study of reducing doses in people who have a bona fide diagnosed addiction to prescription drugs. This study was with volunteers. They had a diagnosed addiction to pills. They often started with pain, and they wanted to be taken off. And it was done slowly. It was done quickly. It was done with an additional medicine called buprenorphine for a period of time. It was done without. The reality was that at least in this extreme group of people with diagnosed addiction, the failure rate was 91.4%. Think about that. Are the people who are receiving high-dose opioids today like people with addiction? Maybe not exactly. Maybe there's a gray zone between functioning well on pills that you get from the doctor, functioning not so well, aberrant behaviors, and having straight-up addiction. Will everybody have a 91.4 failure rate if they're tapered voluntarily? Probably not. But this is the only trial we have of voluntary taper in people who might have some pretty complicated behaviors, and it doesn't look too good. I want to illustrate this with a story that's very troubling. This is a public story. It was first written up by the wife of Jay Lawrence, and I got signed permission from her to review the story, to review the record, to have an external person review the record. This is not going to be a story of why opioids are great. It's not going to be a story of why opioids are terrible. It's going to be a story of how life is complicated and how tricky it can be to figure out how to take care of somebody when there is a long-term history of pain and opioids are involved. Let me walk you through it. The background was that Jay Lawrence had a car crash and had undergone a lot of hard physical labor in the 1990s, and he had injuries. He also had a history of alcohol use disorder, or alcoholism, but he stopped drinking. He met his future wife, Meredith, in 2005. She was also had stopped drinking. In 2007, he started to have loss of feelings in his legs. He had blackouts. He had falls. The explanation for this wasn't so clear. Maybe there was something spinal. Maybe there was more. But between 2007 and 2010, he had multiple back surgeries. He was treated with opioids. He was treated with what I abbreviate as BDZ, benzodiazepine sedatives. He had a stimulator put in. He had a pump inside that area around the spinal cord. So it's called an intrathecal pump that could pump morphine and other chemicals very, very close to the spinal cord. In 2012, they realized that there were actually some brain changes, trauma-induced dementia. And then there was some broken lead to the pump or the stimulator in 2013, which had to be fixed. And panic attacks emerged over the years that unfolded. By 2016, these are the medicines that Jay Lawrence received. He was on morphine at 120 milligrams a day from a pain clinic. He was on intrathecal morphine, which means that it was in that pump, at 19 milligrams a day, as well as clonidine. From his primary care provider, he had received a sedating drug called alprazolam, which is also known as Xanax. And the dose had actually been reduced at the insistence of Jay and his wife, but he seemed to be kind of stuck at that dose. How was he doing on this dose? Pain was always present. Disability was high. On good days, Jay was able to walk the dogs. He could make outings to Walmart. He could prepare coffee for his wife. On bad days, he had pain, sitting in a chair with tears running down his face. This is not a story that should advertise opioids per se. It's just a story of a human situation. Things changed, however, in an important way in February of 2017. His dose was taken from 120 to 90 by his pain expert doctors, who said that state and federal guidelines directly required them to do that. Now, if you've listened carefully to what I said about the Centers for Disease Control Guideline, it didn't say that. I can't speak to the state issue. They also insisted that he end the Xanax or alprazolam because, and this is in the CDC Guideline, there's an accelerated risk of an overdose event when two sedating substances are combined. I said that throughout this talk. So they said, look, you have to go off it. But what you go on and what you go off could sometimes be different stories. It's sometimes hard to run backwards from where you ran forward. They announced to him that the plan for him would be to take the dose down from 90 to 60 1 month later and then to 45 a month after that. My interpretation is that there were severe injuries of many kinds, some caused by the work, some caused by the alcoholism, some caused by the healthcare system and all those surgeries. And there wasn't going to be a clear fix ever for Jay's situation. There were long-term changes that might have predisposed him to react in a different way to opioids from the alcohol use. He had the dementia. He had iatrogenic harms, which means harms from the medical system, polypharmacy. I would apply a word here which is not meant to suggest addiction, but opioid dependence, meaning that stopping the opioids would be hard, even if we do not assert from a review of the record that he had addiction, and no one did actually in his record. There was relief admixed with dependence, which can be a hard thing to fathom. His condition was tenuous, and his tapering the dose would be a high-risk activity. In fact, it was a high-risk activity. Together, he and his wife decided to buy a .44 caliber Ruger, which he shot himself through the chest with in the front seat of his car, with his wife holding his hand. And this was an agreed-upon decision that they felt they had no choice to make because he would not be able to survive otherwise. Of course, his wife was charged with something that was pleaded down to something like reckless endangerment. And I want to quote her. Think about how horrible it was to lose the person you love because the doctor has taken away the medication. As much as I hated losing him, I understood why he made the choice better than anyone else could. And she told me that he wanted her to tell this story. And that's why I think it's partly important for us to know that things like this really are happening. And they're happening in a way that's beginning to reach the attention of the media. In stories across the country, reporters are beginning to notice that these dose reductions are not always working out as well as one might have hoped. And they're not always necessarily, and it's not just the popular media, but even more scholarly sources that are beginning to report this. Of course, one of my graphics came up behind the other. Finally, I want to mention some data that has been put on a public website. I know more about the data, but I'm essentially allowed only to say what is on that public website. When I talk to you about this data, I want you to understand that it's not a peer-reviewed paper and that it hasn't been fully presented. It's just a little bit of a hint of concern. These data were approved for release by the Veterans Administration. It was comparative analysis of veterans who were discontinued from opioids, either short or long term, compared to some who remained on them. And they looked at 2 different years, 2010-11 and 2013-14. Most patients were on low dose, less than 90. And most of the overdose and suicide deaths occurred at those low doses. The abstract is published on the National RX Drug Abuse and Heroin Summit says that where there was a discontinuation or a cessation of opioids, we don't know that it was voluntary or involuntary, there was a high rate of suicide. Where there was a discontinuation or a cessation of those opioids, there was no decrease in the rate of overdose deaths. There's other data to suggest that most of these discontinuations typically are initiated by clinicians who've got concerned about the patient. Has this happened elsewhere? No one else has looked. Let me make something very clear about this. We're talking about a hint of a large correlational database. The temptation is to say, oh, stopping the opioids caused the death. I just showed you how that could happen. I don't want you to assume that we know what this means at this moment. I want you to assume it's another large database correlational study which has something complicated going on. It's a hint and a hint of concern. Something that was supposed to get better didn't get better, but it's also not a full story. That material needs to be presented in full. And just as I'm not entirely sure that we can accept every large database correlational study about dose causing all the overdoses, turns out to be complicated, I'm not sure we can assume from this that every time opioids are stopped or discontinued, a person is at risk. Maybe there are actually people who are benefiting immensely from that. Maybe other people are harmed. Maybe other people are just unstable people who really need care that we're not exactly providing. This is a slide I showed you before. The fall in high-dose prescribing has not yet been associated with a decline in overdoses from those types of opioids that are commonly prescribed. A few conclusions and closing thoughts. I strongly believe, based on what I've seen, that prescribing contributed to today's problems. There's a correction becoming an overcorrection, in my view. That's my opinion. Opioids remain a highly problematic drug for the treatment of chronic pain because nothing works perfectly for everybody, and these ones have side effects, but they're sometimes necessary. The policies that are focused on just taking down doses don't address most of the overdose risk, which appears to be people who have complex disorders and are often at lower doses. There are unintended consequences from pushing these policies as our primary response. These include out-of-pocket costs, patients who are abandoned by their doctors, forced procedures where patients are told, hey, I'll prescribe, but you have to have this procedure done to you in my clinic to pay the bills, basically, and suicide. There could be health system costs. I ask this question, how many other areas of medicine do we do things to patients against their will with this level of evidence? I don't think the evidence is very clear here, and I hope that this gives us reason to think and to pause as we look at the policies that are going forward. There are many complicated human situations, including some where the dose reduction is the thing that saves the patient's life, and others where the dose reduction seems to be the thing that takes it. And I hope people will will entertain some questions and people will cogitate on that.
We will put back on the telephone number and the email address to ask questions. And I do have one question that came in. You talked about studies around substance abusers that tapered. What about just patients that go in for surgery and then their medication after 30 days is not renewed? And there's no transition with that. Can you comment on that?
So the phenomenon we call dependence is itself complicated. A person can have some biological changes that we would see in dependence almost instantly. So if you're going to be on opioids for a while, it's often better to reduce the dose slowly But that said, there's a lot of people who in fact might take a week of hydrocodone 3 times a day and say, A, it helped, B, I don't like how I feel, I'm stopping it now, and they might not feel anything. Other people that are on for a week, 2 weeks, 3 weeks, maybe a slightly higher dose, and they don't feel right when the pill stops suddenly. On average, I think most doctors would say, hey, if you've been on for a few weeks, probably better to go down slowly. But we don't have much science to guide these recommendations. There's not a lot of science about how to stop opioids in a patient who's been on them before surgery and then is on them for a while afterwards. There are some people who do develop new onset addiction after surgery. As best we can tell from papers recently published, that number is low, and the risk is higher with young adults. But that can happen, so it can be an important event for an individual.
Can you comment on the fact with the younger adults and the fact that we're seeing higher levels of alcohol and pills being available to young adults? Can you comment on that sort of for the future of what we're looking at?
Age 14 to 25 is the prime years for developing new onset addictions. And that's to whatever's available. It is not the case that today's young adults are much higher or much more likely to use drugs than their predecessors. There's data that are collected by the federal government that suggested we had kind of a major peak in the early and mid-'80s, and then kind of a slow decline till about 2000, and then kind of a gentle rise in addictions generally in young adults. The use of prescription pain relievers by young adults has been on about a 9 or 10 year decline. So it seems like a lot of the people who, but I mean, I have personally gone to the funeral of a high schooler who seemed to have gotten a lot of pills and just overdose. I mean, it still happens for real. And there are young adults at age 23 who have surgery and develop a new onset addiction, and they lose 7 years of their life. At the same time, so I would say this. If you're the parent of a young adult who is going to receive opioids for a short period of time after surgery or dental procedures, I don't care whether they're under 18 or over 18, try to control the bottle. Treat it as a severe and serious responsibility.
Are there any other questions of the audience? Cindy?
Thank you, Dr. Cortez. It was a very good presentation. I have a question about Narcan. Can you talk a little bit about who should receive Narcan? How do people get Narcan? What's the cost of Narcan?
Oh, okay. So Narcan is also known generically as naloxone. It's an opioid reversal agent. It works for a short period of time, but it basically springs those opioids from the opioid receptors, which are called mu receptors in the brain. For a person who is seeking to be drugged, it's a pretty bad experience. But for a person who's now unarousable, it's a lifesaver. It can be used in the situation of a person who uses heroin, illicit fentanyl. It can be used in somebody who has taken prescription opioids or illicitly derived prescription opioids. At this point in time, in most states, maybe all almost, a person can actually walk into a pharmacy and say, I want to buy Narcan. And there's a standing order from the legislature or from the medical officer that they can get it. The price tag runs from between $25 for a vial or two up to $1,000 depending on the form that you get. There's auto-injectors. Those are very costly. They coach you through injecting yourself. There's a vial that you can put in a little nasal sniffer, and that's actually $25 to $50. But the price has risen. As a doctor, I tend to think about prescribing it when the dose is high. I still consider high dose a concern. Multiple medical problems, multiple sedating drugs, multiple in history of addiction. All those are people where if I'm prescribing opioids, I kind of like them generally to have Narcan too.
We do have another question that came in. What about the use of cannabis, CBD, in the tapering process?
I have no expertise in that issue of cannabis in terms of replacing opioids. There is a National Academy of Medicine report suggesting that opioids may have some benefit for certain kinds of marijuana and cannabidiol might have some utility for pain. I think the data is very unsettled. And of course, addiction is possible with marijuana. So I consider it a completely unsettled issue. But if you've ever been taught that there's no such thing as marijuana addiction, please remove that idea from your mind now and realize that that can happen too.
Thank you very much. Any other questions? We are getting towards the end of the program, and we just want to thank you so much, Dr. Cortez, for being here. And thank you. We want to thank our audience for watching. It was a very thought-provoking presentation. So it looks like we could do a part 3 and a part 2 to this and have a very robust conversation. You can visit our website for more information or to review the program on demand. We hope everybody has a wonderful day. And again, we want to thank Dr. Cortez.
And it was a pleasure. Thank you very much for your attention.